least it works.
Hi, Julie.
Good morning. How are you?
Good, Julie.
Good. So Alicia's online. I've made her a co-host, and I shall make you a co-host as well. I hope this works because we had some difficulty just now, Rahul. Weird. So Alicia, can you try to share your slides?
Yeah, sure. Let me try and see if it works. Second. Okay, let me see. Can you see this?
Yep, beautiful.
Okay,
Got
perfect.
it. Okay, so you're in charge now.
All right, let me.
It'll be great if no one joins because we sent the wrong link.
Yeah, I don't know. Because you know how sometimes there's a different one for the panelists or whatever. So
Oh no, we're not that swanky. No.
Yeah, I don't know.
This
Okay, well, good. You can see it. That's fine. And then
yeah.
Leslie sent me her slides, and I just put them all in one thing, so I can.
Okay, good morning, everyone. We'll get started. So welcome today. I have no idea how to go back onto my other screen. Okay, here you go. So welcome. This is a series of lectures for the newborn care unit in the Royal Hospital for Women, and it's since gone on to several parts of Asia. So thank you for waking up at 5 a.m. Just a few housekeeping rules before we start. We're going to mute everyone that joins in. People will just pop in and out as Leslie and Elisha speak. We'll leave about 10 to 15 minutes at the end for Q&A. Type your questions on the chat pane, but if you really want to talk to the speakers, just raise your hand with the hand icon. We'll upload the talk, it's recording now, if Elisha and Leslie agree to that, and we'll put it on our school website, the WhatsApp, WeChats, Telegrams, and now with Twitter, with Rahul put on Twitter, and it will be there as soon as it converts by Zoom. So today, two great speakers, Leslie Young from Vermont and Elisha Wachman from Boston Medical Center. These two ladies were integral to the development of the ESC tool, the Eat, Sleep, and Console tool, which is probably the first assessment tool that we've had for babies withdrawing from opioids since the Finnegans was developed in 1975. So it's very exciting because we have it from them firsthand to tell us how we can integrate it into our care of babies withdrawing from opioids. So without further ado, I shall pass on to Elisha and Leslie to take over the reins. Thank you. Over to you guys.
Okay, you can see my slides okay? Yes, hopefully.
Yes, very well.
Okay, well, thank you so much for this invitation. So we're really excited. I've never presented to this group before. So we are here to talk about ESC versus Finnegan. So I'm going to start us off, and then Leslie is going to take it from there. So let's get going. Hold on a second here. Okay, so I want to start off with my favorite picture ever. So this is Loretta Finnegan. This was back in January. She, again, developed the Finnegan tool, which I'm sure all of you are very familiar with in the 1970s, and it's been the standard pretty much since then. And it's been wonderful to speak with her about this transition and this debate. And here she is at 80 plus years still presenting her work, which is truly amazing. So what I'm going to do during my half of the presentation is to give a brief overview of the ESC approach for infants with neonatal opiate withdrawal syndrome, what we know to date in terms of evidence to support this approach, about how we've been able to implement it at our center and also in other centers across the US, and also briefly chat about applications to other non-opiate prenatal exposures. So just starting with the overall approach. So the more traditional way that I'm sure many of you are familiar with in treating babies with prenatal opiate exposure is as laid out here, is you have a baby who may start off rooming in with the mother on postpartum. The babies are typically assessed every 3 to 4 hours with the Finnegan scale, and they get a numeric score. And typically the cutoff scores are several scores over 8 or over 12. And at that point, often what happens is the baby is then removed from the mother's room and placed in either a NICU setting or some other setting for more monitoring, and then often for pharmacologic treatment. And typically scores are monitored, and medication is titrated accordingly. And the average length of stay, as we know, is about 2 to 3 weeks for these babies, and on the longer end for babies that do require medication. So what are we doing wrong with this? Because we all know this never felt quite right. And I think just some things to think about is, one is that, we're supposed to be using non-pharmacologic care measures as first-line treatment. And if you go back to the last slide, the first thing that we did when the baby was escalating in signs of withdrawal is we actually removed the first line treatment. We took the baby away from the mother who was providing that rooming in and non-farm care, and we put the baby in an ICU. And so I think number one is we really were not doing non-farm care as first-line treatment. It was sort of adjunctive once the baby had sort of met criteria for medication. The second question is, well, why do we continue to use the Finnegan? What's the evidence to support these cutoff scores that we use? And also thinking about what the goals are of care. I think all of us, working in the NICU and in the nursery, our goal is to keep the baby as comfortable as possible, to make sure the baby is meeting their feeding goals, all of these things, as well as making sure that the mother and baby are bonding. And so if you keep that in mind, ESC sort of makes a lot of sense. And the other thing to keep in mind is, what is the natural course? Like, what is going to happen if you didn't do anything? If you have a baby with prenatal opiate exposure, normally what happens is, the babies will peak in their withdrawal maybe 2-3 days after birth, and then by about a week of life, these signs and symptoms start to subside. And so your goal is to really keep them comfortable during that peak of withdrawal in that first week of life. So this is the Finnegan scale, the original that was developed again back in the 1970s. And some of the things that have sort of called this into question and that make this scale a little bit more challenging is, one is the overlap with normal infant behavior. If you think about, newborns in the first week of life who are often, say, cluster feeding and things like that, they're not going to be sleeping continuously for 3 hours after every feed, which can alter some of the numbers on the scale. The other thing that we find as well is that the infants are often co-exposed to a lot of other medications like nicotine, psychiatric medications, benzodiazepines, SSRIs, things like that, which tend to also cause a lot of the same central nervous system disturbances. So we used to find that kids were scoring 8s within the first 24 hours, but otherwise we're feeding, we're doing fine, often due to these co-exposures. And so the other thing that, those of us that work in the NICU understand is that, often prematurity really just makes this so much more complicated. And how do you really assess, babies that are struggling with things like, tachypnea, really hard to assess what is withdrawal and what is another comorbidity for these babies. So what are we doing wrong? So I think in thinking about the scale, it was developed in the 70s because they really didn't have anything else at the time as a standardized way to look at these babies. And it was from a group of heroin exposed children. And, this cutoff score of 8 was really based on their experience. And I think there was not a lot of data to support that if you used a different cutoff, that there would be any sort of adverse outcome. So I think that's important to keep in mind, that this cutoff score was not necessarily based on, sort of rigorous work to say you should use this versus another number. And I think, at least for us at my center, we were so tied to the numbers and making sure that they were less than 8 that we often created this iatrogenic withdrawal in these kids that were in the hospital often for over a month, sometimes on 2, even 3 medications in our attempt to get the score less than 8, which really didn't allow us to look at the baby and talk to the mother about what was really going on, because we were so fixated on what the number was. And if you think about it, you know, if you didn't know that this baby was a baby who was opioid exposed, I think common sense would say that you would want to wrap this baby up, pick them up, and they would most likely console. And, you know, if you were to score them in both sort of settings. So I think a lot of this, we were not using the same approach that we would use for babies in other settings. So going along with this, there actually is quite a bit of research to support the use of non-farm care for NAS. This was a meta-analysis that came out in JAMA Pediatrics, which showed that if you keep the baby in a non-ICU setting, or at least in a setting in which the mother can be present in the same room, that your need for pharmacologic treatment is drastically less. And this has been pretty consistent across, you know, every publication that I've seen. And it just makes sense. You keep them, you know, in the room with the mother, they're going to do, you know, much, much better. This was another study that was done out of our group and in Boston, which actually measured the percent of the time that the parents spent at the bedside. And this was a group that was actually already on pharmacologic treatment, and we found that the percent of the time that the parents spent at the bedside was directly correlated with every single outcome that we looked at. So it's not only that you have the physical space to have the mother room in, but that they're actually there and that they're engaged, which makes a difference. So this whole concept of Eat, Sleep, Console really, basically what we're saying is that we accept the fact that these babies are going to have signs and symptoms of opiate withdrawal in the first week of life. We know this is going to happen. And our goal is to ensure that while they're undergoing this withdrawal, that we're able to make sure that they're doing what any other infant should be expected to do, meaning they can eat what would be expected of any baby in the first week of life, that they're able to sleep what you would expect for any other newborn in the first week, and that you're able to easily console them so that they're not uncomfortable. And those are really our goals of providing care for these babies. And I think really central to this approach is that we truly believe that the mother is the first line treatment for the baby. So the other thing that is a little bit different with this is that we really encourage discussion about the baby, including with the mother, before we start medication. I think before, I remember when I was in training, you know, you would just get a page that the baby had 2 scores of 8 or 3 scores of 8, and there would be no discussion, and the baby would be written for morphine. So I think this is really looking to say, can we talk about it? Are there aspects of non-pharmacologic care which could be improved before we start medication? Does the baby need more feeding support? Is that the issue? So it really puts this as sort of like a step before starting medication, is to really discuss it and to make sure that you're including the caregiver in the discussion. So this whole concept was first developed by Matthew Grossman at Yale. So this, he really took the kids out of the NICU, started this whole non-pharmacologic care bundle, and then developed this whole concept of ESC. And in doing that, you can see here his sort of first paper on this, which was now, 3 years ago, showed a significant drop in the percent of babies that were treated with morphine. And so we basically decided to replicate what he did after, you know, hearing about this. Things is at PAS. I'm sure Julie was there as well. We were chatting about this, and I said, "Wow, you know, our baseline treatment rates at Boston Medical Center were like 85%." And it just didn't make sense. What are we doing wrong? And so we really tried to replicate what they had done at Yale, and we did this over the course of about 6 months, so it was pretty quick. But we did a lot of education about how important non-farm care was, and I think this first cycle here was probably the biggest hurdle. We basically told the staff, if the baby is scoring over 8, the first thing we want you to do is to put the baby back in the room with the mother and put them skin to skin or breastfeeding, something. So the exact opposite of what they have been doing for many, many years. So this was probably the biggest culture change at our institution, was the discussion and the putting the baby back in the room first before starting medication. And it was about 6 months later that we actually implemented the formal ESC care tool, which I'll show you. And so if any of you are wondering if your center can do it, you absolutely can. So here is our staffing model at Boston Medical Center. We have babies on 3 different units. So we have our postpartum unit, we have inpatient pediatrics, which is actually where we house the babies after moms are discharged. We send the whole dyad together to pediatrics to continue to room in. However, there's a subset that do go to the NICU if they're premature or if there's another medical indication, like if they're tachypnic, that there's a subset that will come to us. And so we had to make sure that all of the staff on all 3 units were in service on this change. We also have 140 pediatric residents that rotate day and night. And so we counted, I think, over 300 people that needed to be updated on this new model of care. And basically, this is what we did: is we made sure that we had representatives from all of the units included, and we had a very large quality improvement team that met once a month, sometimes twice a month, and we discussed every single case. We collected data on a monthly basis, and we reviewed it in real time as a team. We also interviewed a lot of the staff and the mothers early on to get their feedback about what they thought the barriers were to optimal rooming in and non-farm care. And then we actually asked Dr. Grossman, as well as the folks, Bonnie Whalen and her team from Dartmouth, to come to our center to talk directly to staff. And I would say that's probably the most impactful. That was a turning point for us, because they were able to hear firsthand from another team that was not me, to say, this is how we did it. And I think after that, things really started to change. And so again, like I said, culture change, it was really changing our language to the mothers. So instead of saying, be here when you can, it was, you are the primary treatment for your baby. We would like you to be here as much as you can. You're part of the team. And it was a complete change. Now the moms did not want to leave the bedside, and they made arrangements to be there because they really felt included and part of the team. In terms of our ESC specific education, I think a couple more details here for you is that I think having champions, nursing champions, was probably again, one of the most important factors, is that we had staff nurses that really believed in this and that were able to help us roll this out. We did do in-person in-servicing, as well as we made standardized training PowerPoints that was shared with all staff. We also did some case examples that were built into their education so that they could all demonstrate that they understood the tool, that they could score with the tool in the same way. And we would do monthly in-services for the rotating residents. And now we do sort of annual education with the nurses. And again, we started with this easing everyone into it. Let's just talk about it and do some symptom prioritization. So the symptoms that are highlighted in red are the ones that we were really focusing on as being more important than some of the other signs in deciding about medication. And then we developed this formal tool, which was developed in combination with Yale and with Dartmouth, just trying to standardize the Yale approach into something that could be, that everyone could do the same way, that we could build into our electronic health record. So we developed this over the course of that year. And again, here it is, just a snapshot of what it looks like in our electronic health record. So the nurses are using this every 4 hours, the same way as they were using with our Finnegan tool. And then they are asked to document every 4 hours this non-farm checklist, which is another big change. So we really feel like this is so important in first-line treatment. We should actually be looking at it frequently. So this is something that they're actually reminded of every time that they're documenting on the baby. And so at our center, we were able to drop pharmacologic treatment rates by 40% after making all of these changes. But you can see here, it was about 6 months after we made those other changes. So it's really a whole package approach. ESC is not a magic bullet. It's really this combination of this non-farm care bundle combined with the ESC that led to the change. And similarly with our length of stay, we saw about a 1-week difference with this whole non-farm care ESC approach. And so in terms of the US, this has really been spreading very quickly. You can see here the states that are in blue, those are entire state collaboratives that have adapted this approach. So most of New England and a couple of other centers. And then the green states and yellow states have more isolated centers which have adapted this approach. But you know, it's definitely spreading very rapidly, which I know Leslie will talk a little bit more about that in her talk about what is being done to study this further. Just to share our work from our state collaborative in Massachusetts, so we have 37 hospitals working together on improving care for these babies. And so we implemented this across the state over about a 2-year period. And I'm just going to show you here. So there was 11 hospitals that we analyzed as part of our intervention. And I think in terms of spreading this across the state, some of the things that we did was we held statewide workshops. We held a webinar series. We had a standardized training package, which we put on our state website so that they could just download the whole package, which included a video, a manual. Everything was sort of set for them. They didn't need to create anything. They would just take what was on the website back to their hospital teams. And you can see here it was a mix of academic centers and community hospitals that participated, but pretty large numbers that we analyzed in this first paper. And we were able to see, actually, if you look here, and I think this is relevant for you guys, because I know you have a lot of additional non-opiate exposures, but we actually had quite a few infants, particularly in the post-ESC group, that were exposed to other substances. So you can see, you know, up to 20% cocaine, 25% marijuana. We had a lot of psychiatric medication co-exposure, and really actually more in the post-ESC group. So often these babies were polypharmacy exposed. And in addition, let me see here, we were able to see overall that kids were being moved to less intensive care settings. So moving out of the NICU, there was more breastfeeding, more rooming in the post-ESC cohort. And then we saw about a 20% drop across the state in need for pharmacologic treatment. But again, as mentioned before, this is a package approach. So you can see all the other changes that these centers made, rooming in, prenatal education, breastfeeding, were all implemented by these centers, in which case ESC just sort of fits once you've made all of these more sort of cultural changes in your care model. Let's see, and this is just to show that it was maintained over the 7 quarters post implementation, which is reassuring. The other thing just to point out too, so again, here's our regression models here. You can see that we did see about a 20% drop in length in pharmacologic treatment, but also on the bottom, we didn't see any increase in our 30-day readmissions or ER visits, which is also important to keep in mind as these balancing measures. So I guess sort of key to success, I would say, is the standardized materials, getting sort of buy-in from key people in your hospital. These plan, do, study, act cycles, you know, really just pick one thing and change one thing at a time. Don't try to do too many things at once. Sometimes hospitals have done one step versus another first, depending on what they think will be most successful. So I think that also has helped identifying your champions. And I think if you do one thing, I would say rooming in is probably what's going to make the biggest difference in the outcomes. And lastly, partnering, if you can, with prenatal providers has been another thing that's really helped as well. And I think just about done. This is the New England Collaborative, which you can see they've implemented across 3 states in New England, and showed essentially the same results. And then lastly, the state of Colorado has been the other state that just published their results in hospital pediatrics, similar across their collaboratives as well. And they also used the formal ESC care tool in their publication. So my last slide here, how do you apply this to other exposures? So I think obviously the length of time that you'll watch the baby really depends on what the exposures are and what you know to be the half-life of of that particular substance. But I think the core of being able to assess the baby's ability to eat, sleep, and console, what you would expect for any other newborn and what is needed, and looking at those non-pharm interventions, you can apply to any baby with any exposure, because this is still very applicable. I think what the difference is what the intervention will be. And the intervention may not be morphine or methadone. It may be that the baby needs more intensive non-pharm care or a specific feeding intervention. So I think that is something that will need to be individualized, but the whole approach of using this to assess how the baby is doing is something that could definitely be applied in other settings. And lastly, I repeat, it's not the magic bullet. I think it's a whole package approach to change, and most of it's going to be what's on the bottom there, the rooming in, the parental engagement. So that's all I have. I'd like to thank everyone from our ESC team and from Boston Medical Center, and I'm going to pass it on to Leslie.
Great. Thank you, Elisha. So to introduce myself, I'm Leslie Young. I wear two hats when it comes to ESC. As a neonatologist, as Elisha had alluded to, I practice in Vermont, and our site has been utilizing the eating, sleeping, consoling care approach for a year and a half to 2 years now, and with great success. The other hat I wear is as a researcher for the Idea State Pediatric Clinical Trials Network, and I'll talk a little bit more about the collaborative that we're a part of. But that, with that hat on, I go to the conferences and PAS and the National Academy of Pediatrics conference, and kind of hear everybody's enthusiasm for ESC, and folks who note how well it's working, as Elisha has pointed out from the numerous publications, and want to pick it up really quickly and implement it at their sites. It shortens length of stay. This is great. We get them home earlier. And that just made me pause and think and take a step back to say, gosh, is this really something that will work at all sites? So that's where this question of further study comes in, and that's where I'll start. A couple of other pieces when talking about eating, sleeping, and consoling, and when I'm talking about the trial that we are moving forward with. To Elisha's point, it is a whole package, and so as I speak to the eating, sleeping, consoling care approach, that is a care approach inclusive of the formal ESC care tool that also encompasses this bundle of care with the non-pharmacologic pieces. So, next slide, please. Great. So the why behind this, we'll start with the first bullet and come back to the second two, but the evidence to support the ESC care approach is at this point, with the exception of Colorado, largely limited to regional quality improvement work, which really brings into question this issue of generalizability. Next slide, please. Here you'll see a map, so this is of the United States, showing the incidence of NOWS per 1,000 newborn hospitalizations, and this is NAS or NOWS by state. The darker the blue gets, the more cases there are per 100,000, going from the lightest blue of less than 3 cases per 1,000 to the darker blue with 11 cases per 1,000. Now, this is with the caveat that the darker blue is greater than 11 cases per 1,000, with places like West Virginia at 48, so definitely more than. And the map, as you see it, kind of this heterogeneity to it, really is kind of speaks to what the opioid epidemic has been for us. You know, it started with a bang almost 2 decades ago in kind of the northern New England area. There were various tracts of it kind of headed down to the center of the country. But it's an epidemic that has really occurred at different points in time for different places, and has led to what we've seen is really different infrastructures established in different locations. Practices and procedures are different kind of regionally across the country, and there's great heterogeneity to how practices have been picked up and how these babies are cared for. And this has all kind of come to light more recently as the opioid epidemic, as it's been called in the United States, has been really focused on. With that focus, and you can head to the next slide, have come opportunities. The Act Now Collaborative is a collaborative that my trials network, the Idea States Pediatric Clinical Trials Network, is a part of. It's a collaborative between the Neonatal Research Network and the ISPCTN, and really looked to harness the trial expertise of the Neonatal Research Network, as you can see there represented in states that are blue, with the newer trials network through the Idea States that really had a lot of locations in rural and underserved areas that often were most impacted by the opioid crisis. Act Now stands for Advancing Clinical Trials in Neonatal Opiate Withdrawal, and that's really the goal. So the funding came through the National Institute of Health. And our first year in 2017, there were 3 directives. The first was really to take a step back and to look at the population broadly, to take a look at how these babies were being cared for, characteristics of the mothers, of the infants, and really get a sense of what was happening across our sites. Next slide, please. So this first study was the current experience study. It was a retrospective chart review. It looked at 1,377 babies born at these 30 sites across those study periods that you see there. It was all infants who were greater than or equal to 36 weeks and who met our criteria for NOWS. And I'm gonna pull out a couple of pieces from this that I think really highlight kind of the variation that we're seeing between sites. You can head to the next slide. We saw substantial variation in maternal and infant characteristics in infant management and in short-term outcomes for infants with NOWS. And I have to say that the data that I'm about to present is under embargo currently. This manuscript is in press, but we've got permission from the journal to share it here. So next slide. So I'll highlight prenatal care. As Elisha had alluded to, prenatal care and engagement with prenatal providers is really important in kind of cultivating that relationship with the mom and highlighting the importance of her role for her child. It decreases the risk of pregnancy complications, reduces the risks of fetal complications, and can be often limited during opioid addiction. Next slide. And here you can see the variation. So to walk you through this a bit, each dot is a site. So we've got our 30 sites. And here we show the variation in the proportion of mothers at each site that received adequate prenatal care. We have a generous definition of adequate prenatal care. It was greater than or equal to 3 visits, with the first visit occurring before the 3rd trimester. But you can see there's huge variation between our sites, from 30% of moms receiving adequate prenatal care to all moms receiving adequate prenatal care. Next slide, please. When it comes to medication-assisted treatment, we know that medication-assisted treatment can be very helpful in improving adherence to prenatal care and participation in treatment programs. It's an indicator of mothers who are kind of on a path to wellness, or potentially so, and less often in kind of an active use state. In the published work thus far for the quality improvement work for ESC, overwhelmingly the sites and the states that are represented there have a very high proportion of moms who are receiving medication-assisted treatment. At our site in Vermont, we are right around 85 to 90% of our moms are in a treatment program. So there is some variation in New England, but it all tends to be quite high in terms of the proportion of moms receiving MAT. Next slide. So here you can see the variation in MAT receipt across our 30 sites. And again, there's just huge variation from 6% of moms receiving MAT to 100% of the moms receiving MAT. The mean there is, I'm trying to remember, at just about 50, just over 50%, 55%. But that's less important really than just looking at the variation. It really is just across the spectrum there. Next slide. And then the last piece that we're going to look at is antenatal exposure, because I think that's really important. And I know that you guys have some different exposures in addition to opioids than perhaps we do in the US, or at least in New England with Elisha and I. So moms are exposed to opioids for various reasons, but we know that moms who use opioids tend to have higher potential for polysubstance use. It's quite common across that. And we know that babies who are exposed to polysubstances can be much more challenging in terms of their withdrawal state. Next slide, please. And here you can see the variation in antenatal exposures across our site. So when it comes to polysubstance use at the top there, this was an opioid plus one or more other psychotropic substance, and this was exclusive of nicotine, so nicotine was not included in this, it was excluded. And you can see our sites, so each dot is a site again, ranged proportion of babies with polysubstance exposure from 30% to 100%. So some sites had far less polysubstance exposure than other sites. And down below, you can see the number of substances. So this is the mean number of substances at each site. And you can see the variation there from just over 1 to just under 3. Interestingly, with this, there were 170 unique combinations among our babies. So there's just a huge variation in the number of exposures that these babies have, which just makes it that much more challenging. Next slide, please. So it gets back to the why. So you can see there's great potential for variation in these sites and in the populations that we see that can make generalizability challenging. But despite the quality improvement work that's been done, and I say that this quality improvement, I mean, Elisha, hats off to you and to Bonnie and to all those involved with NEPQUIN and the other quality improvement collaboratives. But this quality improvement work has been very, very rigorously done. It's just been wonderful to be a part of. But there are limitations that are just intrinsic to quality improvement work. And so the potential effects of the ESC care approach on infant safety and infant and family well-being following discharge are largely unknown. So these are the long-term outcomes, and they're important. If this is the care approach that is the best for our babies, it'd be nice to build a safety profile and to really kind of gain the evidence we need to get folks on board and to support this. Elisha alluded to a debate very early in her talk, and it's true, there is a bit of a debate in the United States about whether ESC and the ESC care approach is the most appropriate way to care for these babies. So rigorous study is needed. Next slide, please. And this is where our study comes in, is the Eating, Sleeping, and Consoling for Neonatal Opiate Withdrawal, a function-based assessment and management approach. The ESC study for short, we keep it simple. Next slide, please. So this study is really looking to compare the ESC care approach. Again, that's the care approach focused on non-pharmacologic care and parental presence, in addition to the ESC care tool, so it's the big bundle, to usual institutional care using the Finnegan or modification thereof. So usual care with the Finnegan. It's a step wedge cluster randomized design trial with randomization at the site level. There's 26 sites in 18 states, and you can see those states delineated there. Next slide, please. Our primary hypothesis is that among infants evaluated for NOWS, the ESC care approach will reduce the length of time until infants are medically ready for discharge by an average of 4 days compared to usual institutional care with the Finnegan. Next slide. And our medically ready for discharge, we chose this really to prevent the protracted stays that can occur due to social holds for our babies. So instead of choosing length of stay, we looked at the time until they're medically ready for discharge. Sites will discharge their infants based on their usual practice, and then our study team will go ahead and consider an infant ready for discharge at the point at which they were discharged or at the point at which they meet all of the following criteria, and those are listed there, and it's whichever occurs first. Next slide. Our secondary hypothesis is that among infants evaluated for NOWS, the use of the ESC care approach will result in an improvement in infant neurobehavioral functioning and family well-being when compared to usual institutional care with FNAS. Next slide. And again, here's our study design. So it's a step wedge cluster randomized controlled trial. Each block will include 3 to 4 sites. So our 26 sites were randomized into those 8 blocks, and our 8 blocks have been randomized into the order in which they will transition into ESC. So our sites will all start with usual care, and they will have a period in which they'll receive their training at the sites, and they'll during the transition period, they'll subsequently implement ESC and then move forward into their ESC periods. Next slide, please. Every baby at the site will be cared for using the care approach that the hospital is assigned to at the time. So all infants with NOWS will be cared for in that way. During the initial birth hospitalization, data will be collected under waiver of consent for all infants who meet the eligibility criteria. So because we've randomized at the site level, and because it's really a culture change, it's a practice that happens at the site, and all infants will be cared for using this management plan, we're able to collect our primary outcome and many of our secondary outcomes, short-term outcomes under waiver of consent. And this really optimizes our ability, generalizability of the study across the population. Next slide, please. So again, our primary outcome, medically ready for discharge, and then our subsequent secondary short-term outcomes will all be obtained under waiver of consent. Our secondary outcomes are there, and I'm not going to read through those, but we'll go to the next slide. These will be important to highlight. So as part of our secondary outcomes for the short-term portion, we do have safety outcomes, including an inpatient composite safety outcome, an outpatient composite safety outcome. So looking at acute care or emergency room visits, as well as hospital readmissions, and then a critical safety outcome at discharge, 3 months and 24 months. And these are being done through chart review, through linked chart review, through online queries and so forth. And that critical safety outcome includes non-accidental trauma and death. Next slide, please. So informed consent for eligible infants will be obtained from the legal guardians for participation in the long-term follow-up portion of the study. So we acknowledge that we'll have maybe a less generalizable sample, but thought it was completely necessary to go ahead and get some long-term follow-up on these babies. Next slide, please. So our long-term outcomes obtained under provision of consent will include neurobehavioral functioning through use of the infant behavioral questionnaire. We'll look at infant wellness from discharge through 24 months. This will include growth, assessment of sleep through the brief infant sleep questionnaire, look at enteral feeds and whether there's any breastfeeding occurring. We'll look at acute care or ER visits, readmissions, non-accidental trauma and death, and we'll also assess the ACEs, so adverse childhood experiences, through use of that questionnaire. Next slide, please. Additionally, we'll look at maternal caregiver well-being through the PROMIS short forms, infant caregiver attachment and bonding through the MPIQ, maternal caregiver sense of competency through the PSOC, a family environment through the family environmental scale, the relationship dimension, and then finally look at infant neurodevelopment at 24 months through the Bailey-4 and the BITC. So really getting a nice global look at how is the baby doing, and how is the family doing, how are they functioning, and hopefully getting a nice comprehensive look at all that. Next slide. Oh, I guess the only other thing to say here is because our primary outcome is our study is powered based on the number of sites. We then become way overpowered based on the number of infants to potentially show something when we start looking at neurobehavioral outcomes and neurodevelopment, if we were to be able to consent to all of our babies. We anticipate that we'll probably have a 30% consent rate, 30 to 40 is our goal, and we will be powered to show some differences there in neurobehavioral outcomes and neurodevelopment, so that's exciting for our group. Next slide. I believe that's it. And final slide is any questions.
Okay, thank you so much, Leslie and Elisha. So any questions? Everyone's very quiet on the chat pane. So this is really important because this is the first one to look at neurodevelopmental outcomes and safety after hospital discharge. Is that right?
Specific to ESC?
Yes.
Formally, yes.
Yes, that's amazing. When is the anticipated timeline for your study?
So excitingly, we started enrolling babies last week on Tuesday.
Okay.
Yeah. Yeah. So we are off and running. We've consented our first 2 babies for long-term follow-up. And we're having our first training for ESC is the beginning of October.
I don't even have to ask how much the study is going to cost.
I don't know if I'm privileged to share that. It's quite expensive.
It's quite expensive.
But I have to say, it really hats off to the folks. So it's funded through the Trans Agency HEAL initiative, so helping end addiction long term, and that's a huge trans agency NIH HEAL initiative that's really looking to support development of evidence to improve care across all domains, from moms and adults and kids and infants and so forth. And I will say for the neonatal side of things, it's really being done in a nicely coordinated way, such that the studies that are currently kicking off, so in the Act Now Collaborative, there's a second study that involves weaning of pharmacologic therapy. And then there's an additional longitudinal study that's being done as well. And all of those are harmonized to really be able to say something at the end of it all. So it's pretty awesome work.
That's great. I see online, I've got my regional counterpart, Carol Dahan. She's a clinical nurse consultant out in the Murrumbidgee, which is the biggest regional center in New South Wales. Could I ask you to comment on how this ESC assessment tool would fit in with the regional centers where, the hospitals are hundreds of kilometers away from the patient? Carol?
Yeah, good question, Julie. I was thinking that through in my mind when I was watching the presentation. Thank you, Leslie and Elisha, for the for this exciting work. It's great that you've just started enlisting people last week. But yeah, I'm just curious to kind of understand like how does that follow-up happen? And I know these group of parents are often transient and in and out of different living arrangements, but certainly in our rural areas, we have women who are birthing like, say, 300 kilometers away from where they may live, and the care is quite fragmented, given that they're receiving supports from different locations that are also hundreds of kilometers apart, and just logistically difficult, I suppose. So yeah, just reflecting on that. Is that where you're headed with that question, Julie? You're on mute, Julie.
Oh, sorry. Elisha and Leslie, could you comment on the rural patients, the ones that are far away from you?
Oh, this is interesting. I guess I can comment on a little bit, and then Leslie, I'd love to hear from you because of the sites. But I think just to we have a lot of patients even like within our state that are far away, and I would say I guess two things. Like for I think COVID's changed everything for us, and I'll tell you the amount of visits that we're doing virtually. Actually, this morning we did a virtual Bailey, not the in person, but we were able to actually do a lot with them. We've actually had better compliance with a lot of the patients with more virtual visits, home visits, things like that. And then for a lot of the clinical trials that we've done, we've had to provide transportation for them to come in. For some of these, we'd had to pay them to come in. I don't know, Leslie, if you've had similar thoughts for your sites.
Yeah, I'd say in terms of, if I heard your question correctly, just being able to utilize the ESC care approach in a more rural setting where maybe the folks live further away. I will say across our state, we have each of our hospitals currently doing ESC. And it means we see at our larger institution, we see far fewer babies getting transferred to us for sure. So in fact, I think it really kind of keeps, in those cases, keeps those babies closer to home and closer to kind of their family's social network.
Yeah.
The piece that we struggle with the most, I would say, at our site in terms of maternal presence is when they are receiving MAT and they need to travel to get their dosing. And so that kind of disrupts the flow of having them there at the bedside.
Okay. I guess the flip side, it's Carol again, thank you for that. I guess the flip side is it would be, while the women are birthing far from home, I guess it could mean capacity building the sites that are closer to where they actually live anyway, whether it be a small rural facility that doesn't normally birth, or whether it's one that births but doesn't birth the higher risk presentations. Yeah, I think it's got a lot of potential to kind of look at that. Yeah.
Thank you, guys. May I ask Annie from Bangkok, make use of her waking up at 5 a.m. Bangkok time. Annie, you see a lot of non-opioid exposure in your hospital. Could I ask what type of assessment tools you use and how you manage your infants?
In our centers, mostly it's methamphetamine, as you know. And to be surprised, they don't have very much symptoms at all. So we kind of approach as the team after we discharge them. We have another team to follow them up at home. And they seem to be okay because most of them are teenagers or something. So we don't have quite a serious babies with NAS at all. So this is very interesting how you can manage them. Thank you.
What scale do you use, Annie?
We use Finnegans, and it's almost zeros for every case.
Yes, that's the concern we have with the methamphetamine babies. They're usually very, very obtunded, and our issue is that they don't thrive very well. They're very good babies. They sit in the corner and don't make any noise. And that's our major concern, because when we send them home, they sort of like fade into the background. Meredith is online as well. Could I ask her to comment on the utility of the ESC in our setting, Meredith? What do you think? Unmute yourself. No, she can't. I'll unmute her. Oh, she's
sorry, Julie, what was that?
Yeah. Okay. So Annie's saying in Bangkok that most of the babies are on methamphetamines and they don't make any noise. So we're concerned whether an ESC tool that's been validated for opioid exposure would be applicable to our babies.
I think that it sounded like it was really promising for polypharmacy, and I think it's a global phenomenon that we're all seeing the polypharmacy as the major issue in terms of managing these babies. So I thought that the tool looked really encouraging. I think the main limitation I saw was just the practicalities of the requirement for rooming in and just the logistics around how we would actually manage that given space constraints and also, as you said, regional constraints in a lot of our local nurseries.
So Meredith, you raise an important part and one that we're really trying to focus with the trial is making it as pragmatic as possible, and really focusing not on being able to do every single piece of this non-farm bundle, but being able to optimize every infant's care in the context that we're in. So whether there are certain limitations on offering non-pharmacologic care, or whether there's limitations to a baby receiving it, i.e. maybe mom's not present, really just not only selecting sites that are able to room in, not only selecting sites that have these pieces in place, but really just selecting sites that across the board will allow us to see whether ESC is generalizable in all these various kind of care settings.
When do you expect to finish this study, Leslie and Elisha?
Yeah, the enrollment period is 20 months, and then the follow-up is 24.
Okay, by that time,
So it'll
coronavirus.
be 20 and 24 is 40.
Yes.
We'll be out of lockdown then.
I'll have more gray hair.
We'll be meeting in person in pairs.
Yes, we did the calculations. My daughter was very excited. I think it actually will begin to extrapolate out to maybe Hawaii PAS.
Yay!
Yes, I was thinking about that too. I'm like, is that the next time we're all going to be together? Is Hawaii?
It might be.
It'll be worth it. It'll be worth it.
No.
Okay, so we're out of time. With your permission, Leslie and Elisha, I would post a recording on our website, of the school website. Is that okay? Or you can tell me afterwards anyway. And if there are any other questions, if the participants can just email me, and I'll pass it on to Elisha and Leslie. So if that's no more questions, I would like to thank Elisha and Leslie for your time and all your amazing work with this topic, and I look forward really to your results. Okay, so thank you very much, and have a good night, guys. Thank you.
Great, thanks.
Thanks. Bye.
Okay.